What's up? Yeah. Just got done with ACLS. That was like 6 hours. Yeah, I'm waiting for you guys to get on here. What's going on? Hey. Literally just got done with the ACLS recertification. That was literally, 5-6 hours. And man, forgot a bunch of stuff. All those rhythms. It's kind of crazy how much I forgot. Anyway, wanted to get on here, jump on, and go over a case of the day. 11 chapter comprehend. Jeez. You got 11 chapters and you're on Instagram right now? You gotta go steady. How many years is that good for? I think that's a good question. I think it's like 3 years. So hopefully I'm good for at least 3 years now. But seriously, God, those rhythms, shockable, not shockable, epi, amiodarone. Anyway, I just got done with that. I'm back. Time to eat some dinner, but wanted to go over a case of the day with you guys. What did you guys think about that? When did I post it? Not yesterday. I think I posted the day before, or was it yesterday? I don't even remember at this point. What were you guys thinking it was? Or I can just straight up put it on here now, which I might do. Let's do that. How do I do this? Where the hell is it? There it is. Okay. Here is case of the day. What do you guys see on here? First of all, let's cirrhosis, right? Let's break it down though. Let's break it down for people who want to go over the basics, and then we'll go over everything after that, okay? So first of all, what kind of image are you looking at right now? Anybody, and how do you know what kind of image is? Meaning, what type of modality is this? Is this an ultrasound? Is it a CT, or is it an MRI? I know, again, we've talked about this before. A lot of people are like, dude, Amrit, why are you asking this question? That's such an easy question. But remember, everybody's on their own path right now. Everybody's on different levels as far as imaging comes along. So this is a CT scan. Remember my little spiel before. I'll say it again, always. Look at the vertebral bodies, the bones. If they're super white like that, it's going to be a CT scan. If they're darker, it's going to be an MRI. So we're looking at a CT scan right now. Is there contrast on board, or is there no contrast on board? You guys tell me that. So contrast enhanced CT scan or a non-con CT scan? Which one? Yeah, there you go. It's 3 gray colored pencils. Exactly. So this is a contrast-enhanced CT examination. And the next thing that I want to talk about is there's different phases of contrast that we can obtain a CT scan in. You can have, again, a non-con. You can have an arterial phase. You can have a venous phase or a portal venous phase. And you can have a delayed phase. And a delayed phase is really good for checking out like the renal pelvis, the renal collecting system, because it's like the excretory kind of phase. So there's 2 phases here. What are the phases that I'm showing you here? Well, the top one is an arterial phase. You may ask, how do I know this is an arterial phase? Well, what's that big structure right in the middle? That big, really opacified round structure right in the middle of that top image? That's the aorta. So we see the aorta, it's bright. And then compare it to the bottom image. Look at the aorta. These are pretty much the same cuts. Is you can tell that the aorta is not as bright on the second image compared to the first or the top image, right? Compared to this bottom image. So we know the aorta is super bright on the top image, and we're going to be like, okay, so this is an arterial phase, contrast-enhanced CT examination up top. And then you have to ask, what kind of enhancement pattern is the below CT examination? We already said it's not arterial, right? Because the aorta is not super bright. Okay, well then what's the structure kind of on the top image next to the aorta in the liver? That's the IVC. And you can tell the IVC is, it's like a little bit opacified. Look at the bottom image. The IVC is a little bit darker than the vessels around it. And those vessels around it are the portal veins going into the liver. So the bottom is a portal venous phase. So we have arterial phase, portovenous phase. All right, so basically this means the top image was obtained pretty quickly after about 30 seconds or so of injecting contrast. The bottom image was obtained like a little bit further on, about a minute and a half after. So we have an arterial phase, portovenous phase. That's what we're showing you as far as the basics. Then you have to figure out, well, what's the abnormality in this CT scan? What's actually going on? The stomach was over here. It's not anything to do with the stomach, or in the bottom image, the stomach has nothing to do with the stomach. It's nothing to do with the vertebral bodies. Anybody know what these black areas of like posterior to the liver or to the sides of the vertebral body? That's air, and those are the lungs. Has nothing to do with the lungs because I did not put it on lung view for you. Basically, what's the biggest organ that I'm showing you here that's encompassing most of the image? It's the liver. So I'm showing you the liver, okay? So liver and then liver. So I want to point out something to you in the liver. Now, if you look at the top image, you see just anterior to the IVC, or the intrahepatic portion of the IVC, just anterior to that, you see this brightly enhancing area. And then if you correspond to the lower image, it's not really enhancing anymore, and it's actually kind of dark now. So now you have to put things together. Is you have this, and I'm showing you the same lesion. It's the same exact lesion. You have a contrast enhanced pattern now. So I can confidently say I have an arterially enhancing hepatic lesion with delayed washout. And you're going to ask me, well, what does washout mean? And washout basically means is the lesion becomes darker than the surrounding hepatic parenchyma. Remember that. It's not washing out compared to itself on the arterial phase. It is darker compared to the rest of the background liver. That's what washout means, all right? So you have an arterially enhancing lesion with delayed washout. Somebody tell me what that is. That's like pathognomonic. Those are buzzwords for this lesion. Anybody? Arterially enhancing hepatic lesion with delayed washout. That is pathognomonic for a hepatocellular carcinoma. Yeah. What does your husband do, Nancy? Let's talk about portal hypertension. Let's talk about adenoma. I'm glad you guys are mentioning this. Yes, HCC, absolutely. And I'm glad you mentioned adenoma. That is a very important differentiation. So, pulm critical care. Oh, yeah, there you go. So, arterial enhancing lesion, delayed washout. That is an HCC, hepatocellular carcinoma. I didn't really give you a lot of reasons that would point you towards cirrhosis on these imaging, or on these two images. But I kind of told you, right, on today's question, I said, hey, does cirrhosis help? A lot of you guys answered cirrhosis correctly, but there's some trauma answers. There's varying answers as well. If somebody has a cirrhotic liver, meaning that is a highly abnormal liver, the hepatocytes are all messed up, it's just a terrible, terrible liver, right? 9 times out of 10, if you see an abnormal lesion within the liver that is a cirrhotic liver, be very concerned for a hepatocellular carcinoma. Before you even start thinking it's an adenoma, before you even start thinking it's a focal nodular hyperplasia, before you start thinking anything else, be very concerned about an HCC. All right, so 9 times out of 10 in a cirrhotic liver, it's going to be an HCC, all right, before you start thinking about everything else. So remember, when we're talking HCC, yes, mainly back in the day, and it still is prevalent, but we have a lot of great medications these days. But Hep C was a big issue. Alcohol cirrhosis is a big issue. Non-alcoholic steatohepatitis or non-alcoholic fatty liver disease is a huge issue these days. That's causing cirrhosis. And yes, it can lead to HCC. Board step 1 questions. Remember, Hep B can go straight into developing an HCC without even getting to the cirrhotic phase. Ronak is asking, what do I expect in FNH? Okay, good. So let's talk about, so that's HCC. The pathognomonic was an arterially enhancing lesion with delayed washout. Remember, the washout is compared to the adjacent hepatic parenchyma. So when you have those two things together in a background of cirrhosis, think about HCC, hepatocellular carcinoma. Think about that. Now, the other differentials for this. One, everybody loves to say FNH and everybody loves to say adenoma because they're great differentials. First of all, for adenoma, hemangioma. Thank you. Thank you for putting that on the differential as well. Hemangioma. Let's rule out the easy ones first. The easy ones being adenoma. You don't even look at the imaging yet. Don't even look at that. Go look at the H&P of the patient and look at it. Is it a female? Okay, it is a female. Then start thinking about adenoma. Is it a young female? Absolutely start thinking about adenoma. Is the patient on oral contraceptives? Absolutely start thinking about adenoma. Is the thing bleeding? Absolutely think about adenoma. Before you even get to all the imaging characteristics, really start thinking about those. Adenomas can be tough to differentiate between FNH and HCC on a CT scan. Yes, the contrast enhancement sequences do help. Yes, physician doodles. Yes, birth control, oral contraceptives. Yes, adenoma. Joshua asks, can NASH versus differentiate on imaging? So NASH is good. Non-alcoholic steatohepatitis. Hepatitis means the liver is actually inflamed. So yes, especially on MRI, MRI will show you hepatic inflammation acutely and chronically as well, and it will show you that nicely. Non-alcoholic fatty liver disease will basically just show you that the liver is fatty. So yes, you can differentiate that. Okay, so that was a little sidetrack. We talked about, man, I'm going on a roll right now. We just talked about adenomas. It can be difficult to differentiate off a CT. If you have an MRI, there are sequences that you can tell. One, you want to see fat in that little sucker. If you see fat in there, then you start thinking about, all right, this may be an adenoma. Number 2, let's go to FNH, focal nodular hyperplasia, all right? This is nicely differentiated on MRI. Again, I'm hesitant to say these are slam dunk off a CT. They can be very hard sometimes to differentiate on CT. So I go straight to MRI or our virtual biopsy. Either I can put a needle in it and tell you what it is, but remember, I don't want to put a needle in an adenoma because that thing can bleed. So I really don't want to do that. And why would I want to, subject a patient to an unnecessary procedure if I don't have to? So off of an MRI, I can tell you that it's focal nodular hyperplasia. This is called the stealth lesion. Stealth, like a stealth fighter goes in the air that you can barely see the thing right now. That's what focal nodular hyperplasia is, FNH, because you can basically only see it on the arterial phase sequence. That's when you see the FNH. It will be bright on the arterial phase sequence, and then it'll just blend into the background of the liver on the delayed, on the portal venous, and you won't see it on the pre-contrast sequence either on MRI. So that's the stealth lesion, all right? Because why is it stealthy? Because focal nodular hyperplasia, the third word hyperplasia, just means there are normal hepatocytes that are just abnormally growing. So they're not actually other tissue other than liver. So it pretty much should have the same enhancement characteristics as the liver. It should be stealthy just like the rest of the liver because it is liver. So the only place you'll see it abnormally is the arterial phase. That's FNH. You'll see it lobular as well. Focal nodular, right? So it'll be lobulated as well. So we did adenoma, we did HCC to begin with, we did adenomas, remember female OCPs, young female. We did FNH, remember it's a stealth lesion. It's basically just hyperplastic liver, normal liver tissue, so you only see it on the arterial phase. And then let's go to hemangioma. What is a hemangioma? This is kind of a vascular-ish type malformation. You're gonna look, you can 100% diagnose this off of CT. You will see nodular interrupted enhancement around the periphery of the lesion. And the beauty of it is if I get in an arterial phase, that those nodules will be as bright as the aorta. If I get it in the venous phase, those nodules will be as bright as the maybe IVC. And then it will slowly start to fill in over time. So if I get the arterial phase, it'll be interrupted nodules on the arterial phase and it'll be bright as the aorta. Then if I go to the venous phase, it will be interrupted nodules as bright as the IVC. I know I'm pointing like this is aorta, IVC. And then it will slowly start to fill in again, and then on the delayed phase, it may completely fill in. So those are your main 4 hepatic lesions. Remember, just to recap for people who are joining right now, if you see a cirrhotic patient who has cirrhosis and there is a liver lesion in there, 9 times out of the 10, it's going to end up being an HCC. Diagnose HCC by saying arterial enhancement with delayed washout. Remember, washout is compared to the background parenchyma on the delayed sequence. Then the differential consideration for that is focal nodular hyperplasia. With this, the stealth lesion will be brighter in the arterial phase imaging. Then there's adenoma. Remember, it's just the demographics. Look at the young lady on OCPs. You'll see it. Don't put a needle in that thing. That thing's going to bleed. And then the last one was hemangioma. I just mentioned that right now. Any questions that I can answer for you guys? Woo! That was a recap right there. Any questions? Any questions? I just got a request. You want to be live with me right now? Yes. How do I pronounce? What is M100? Any questions? Any questions? Yes. No. Stealth mode. There you go. HbA1c. That's a cool name. That's cool. 21, what is this? Are you giving me a clinical scenario? 21-year-old female with fatty liver without metabolic syndrome. I'm new to this, but how can you tell that this is a cirrhotic liver? Yeah, so good question, Newman 316. You can, off of this image, you cannot tell that this is a cirrhotic liver. If I scroll down some more, you could tell that it is a cirrhotic liver. I've uploaded, I believe, some stuff on my YouTube channel. If you just go to my bio and then click the YouTube whatever, there's some past cases of the day that we did talk about cirrhosis. I will do one again on cirrhosis because it is such a huge topic that seriously you deal with every single day. So I'll do one specifically on that. In which lesion MRI is more diagnostic than CT? Every lesion. MRI is so diagnostic because there's such great contrast resolution that it is way better than CT. I don't perform surgeries. I do everything minimally invasive. I don't like to really say. So in interventional radiology, when we talk to people who aren't familiar with the specialty, we say we are like minimally invasive surgeons. I don't like saying that. We do procedures, everything minimally invasive through a small, basically pinhole, something smaller than this. We can ablate stuff, we can kill tumors, we can embolize bleeds. We can literally cryoablate a gallbladder and kill it off. Is caudate lobe hypertrophy quite evident to identify cirrhosis? Caudate lobe hypertrophy, so the two lobes that hypertrophy, left lateral lobe and caudate lobe, those are abnormally hypertrophied in cirrhotic livers. We can go over this when I talk about again, I promise I'll go over cirrhosis with you guys and the sequelae of cirrhosis, and we'll talk about why those two lobes hypertrophy. All right, what else? Yeah, man. Dude, you're about to start residency here soon. I'm talking to Nav right here. You got a couple of, 2 months left. Go find a place. All right, what else? Can I get some dinner now? Or what else? You guys got more questions? Any more questions? Oh, Encantada, nice. That's a good place. You'll enjoy that place. I don't go out there much, but that's nice. Joshua, great content. Still lots to learn. Thanks, man. Hey, still lots to learn for me too. This medicine game, this doesn't end. Sorry for the ignorance. No, don't say sorry for the ignorance. No, ask away. But my attending told me that IR will never treat a patient with vascular disease because that belongs. No, your attending is 100% wrong. Absolutely wrong. We treat vascular disease every single day. Newman, you ever inspired me to... that is the coolest thing ever. Yes, please. We need a PA here. Absolutely. We love having PAs, radiology PAs. You are invaluable to our department. Going back to... No, Cole, please. Let me have a discussion with your attending, and please, that is a big misconception. No, we literally IRs treat vascular disease every single day, whether it be venous or arterial. What about cardiology procedures? You said that belongs to cardiologists. Yes, cardiologists, absolutely. I'm not going to touch a heart. I'm inspired by you, man. Thank you. Thanks for daily. Absolutely. You guys inspire me to inspire you. Everybody needs to be positive and just keep inspiring in life. There's so much freaking negativity in this world. It's so annoying on an everyday basis. There's no point. A lot of people just keep putting everybody down just to make themselves feel better. Stupid. What's the role of PA and IR? Oh, so much, man. So much. Our last PA, she was great. I mean, she made the department run. She unfortunately moved. Well, fortunately for her, she moved to a better job. We miss her. She did all the fluoro studies, paras, thoras. I mean, everything. How's the lifestyle? I love my lifestyle. I absolutely love it. We work our butts off in IR, and but it's so worth it. I go in. I mean, if I get called in the middle of the night at 3 a.m. for a bleed, I am happy to go. I may eat my words at some point in my life, but right now I'm happy for it. I absolutely love it just because I'm passionate about my field. Hey, thank you so much for the answers. Absolutely, man. Anytime. Absolutely. What else you guys got for me? What else? What else? So I'm going to put that on the checklist, cirrhosis. Oh, wait. Alexa, you requested the HCC, right? The HCC question. Oh, and you missed the beginning. That sucks. Well, I'll upload it back up. How's it like to be an IR? It's amazing. It's absolutely amazing. We get to treat everybody in the hospital in one way or another. We deal with every single specialty in the hospital. We do a lot of things. Oh, I reposted. I forgot whose it was. I reposted that in my stories. We're like surgery, but magic. I only say that because a lot of people send patients down to IR having no clue what they want done, or they just want something done. Patients crashing, I don't know, do something. A lot of the times, yeah, obviously we have set procedures for certain things, but a lot of times we're tailoring our procedure. Oh, I can take this picture off, right? A lot of the times we are tailoring our procedure for that specific patient. So we're gonna go in and we're gonna huddle in the beginning of the day and we're gonna say, hey, game plan for this patient specifically. We're gonna do X, Y, and Z. This is not a conventional ABC, and we're gonna try to make it work for the patient. We MacGyver a lot of things. Is that an old reference for everybody? But that was seriously one of my favorite shows when I was growing up. What medical school? I went to a Caribbean medical school, Ross University. Yeah, discussion of various catheters and guide wires. Absolutely. I have a big collection over here of them sitting in my living room for teaching purposes. I can do that. You want to decide between surgery or IR? I highly suggest that you go shadow both. They're completely, yes, they are similar in some respects, but no, they are also completely different in a lot of respects. Remember, to be an interventional radiologist, you need to do diagnostic radiology. Don't forget that. A lot of people think they go straight into IR, which is not true. You need to do at least 3 years of diagnostic radiology. So you will be sitting there reading chest x-rays. You will be sitting there reading abdominal CTs. So remember that. What are the risks in IR? As far as me, my steps 1 score, it was fine. It was good. I have no complaints with my step 1 score. It was good enough to get into radiology, but step 1 scores these days, I was on the admission committee this last year. There's a lot of smart people out there right now. People's step 1 scores are really awesome. Barbershop in Tucson, best answer. Go check out, and I'm going to tell you, or I'm going to tell him too that I'm referring you to him. Go check out, it's called literally Two Sons. It's like 2 eyes, 2 little small eyes, ... and then SONS. And go check out Austin there. Best cut. And I'm seriously due for one. I haven't had a haircut in like a month now, something like that. Just been way too busy. What are the risks in doing IR exposure to radiation? Yeah, we get exposed to radiation every day, but we have lead on every single day. We have thyroid shields on. We have skirts underneath the IIs or the fluoroscopic machines. We have so much radiation safety, it's not even funny. So I'm not worried about it. What else? You guys know you're exposed to radiation when you take a transcontinental flight. So if you're flying from California to New York, you're exposed to radiation. Yeah, go look it up. Ross University, it was fine. It got completely changed. It got destroyed by a hurricane, so it's on a different island now. This was like years after I was there. And med school is 4 years. I spent 16 months on the island. If you eat a banana, I'm sure you're probably exposed to radiation too. P.S. got my own beard thing. Yeah, there you go. You got your own beard going on. Nice. How hot are summers in Tucson? Way too hot. And I'm about to move to LA before it gets crazy hot. It gets up to like 120 degrees Fahrenheit here. Unbelievable. How are you supposed to radiate from California to America? What? How are you supposed to radiate? Oh, just normal. I seriously, look it up. Go Google transcontinental flight. You're exposed to radiation, and say how much radiation are you exposed to. It's more than a breast mammogram. How can I get a shattering rotation? You got to ask around to different hospitals. You got to see who's friendly and who is accepting of whatever school you go to, and go even ask around to other people who. Only 110s. No, man, it gets up to 120. It has. And then if you go to Phoenix, a 2-hour drive, I got out of my car one day in Phoenix. It was like a couple of years ago. It was 126. I walked my ass straight back into the car, turned on the AC, and I drove straight back here. That's hot. Phoenix, they have to actually ground their airplanes when the tarmac is way too hot. Not a neurosurgeon. I respect exactly what they do. Not a neurosurgeon. They do some great stuff. We work a lot with neurosurgeons on various things, but what does a neurosurgeon look like? Sleep deprived? What else? Yeah, can't generate. Yeah, there you go. Yeah, I don't know. I don't really care to. Oh, Kim Bo's giving me eyes. What are you doing? Kim was my program coordinator back in my intern year, which was a long time ago, which was the last time I ran a code on a patient. So I had to think back to that time, which was 4.5 years ago when I was doing my ACLS training today. I was like, this is that rhythm. And yeah, we're going to inject epi. All right. What else? 32 degrees Celsius. I'm not familiar with Celsius, but I think that's pretty hot. I think that's like 90 something. IR has as many procedures as whatever we're comfortable with doing, we can do it. Again, if it's not anything to do with the heart or the brain, but interventional neuro radiologists do the brain, but interventional radiologists who don't work on the brain or the heart, we can pretty much do everything else. Has everybody got research these days? Everybody has to have research just to put them on a level playing field. Do your research. Now you're on a level playing field. Then get your step 1 scores in. Then you're boosted up above everyone else. If you're already in residency, you gotta just do research, and you gotta be. Okay, here's my spiel. People hate, you're in med school, people like, oh, that person's a gunner, right? You've all heard of that word. Oh, that person's a gunner. Don't worry about him. He's just always trying to screw people over, whatever. Okay, there's difference to me is a gunner and a sniper. These are words you probably hear in med school all the time. Be the gunner. Go be the person that's going to go stand out, go above and beyond, go show everybody up. Don't be an ass about it. Be humble about it. Be nice about it, but go work your butt off and go be the hardest working person in the room. That's what a gunner is. I was a gunner. Don't be a sniper, though. Don't stand back and start taking people out, throwing people under the bus, that kind of stuff. Don't do that. Annie Oakley, nice. Hey, that's going to pay off. Don't piss anybody else off. Don't throw anybody under the bus. Don't do anything rude to anybody, but work your tail off. It will pay off, I'm telling you. I don't know what that means. Oh, snipers. You're probably saying snipers. No, I wouldn't say that. No. There's no field in general that I'm saying is a gunner versus sniper. Sniper just means somebody who is working hard, but they're also screwing other people over in the same time. A lot of people, if you get called a gunner, it's probably from somebody who's kind of jealous of how hard you're working. So first we have to do diagnostic radiology, and then interventional radiology, and then subspecialties. First you do diagnostic, then you do interventional, but there is a new interventional radiology residency now. But don't get me wrong, you still have to do diagnostic radiology in that. This is a huge misconception. People think that they're going to apply to IR residency and just go straight to embolizing spleens from these traumas. Absolutely not. You have to be a great diagnostic radiologist to be a great interventional radiologist. If you suck at reading imaging, you do not deserve to be doing minimally invasive procedures on people. So anybody who goes into an IR residency still does 3 years worth of diagnostic radiology. Remember that. Cool? We good? Anything else? I'm starving. I want to go eat. But I love talking to you guys, so hey, keep at it. I'll wait a couple more seconds. Oh, there it is. So it doesn't do IR procedures, and ever since I've been following you, I feel so inspired, just confused. I proceed, can't find a mentor. Ooh, hey, appreciate that. I'm glad you're inspired, though. I'm glad I can help you with that. I do whatever you can to find a subspecialty, somebody who you can shadow. Do whatever you can, however you can do it. Go to a different hospital, whatever. If you have vascular surgeons who do minimally invasive procedures, hey, go shadow them as well. You know, they're doing catheter-directed therapy and stuff as well. Not to the extent that we're doing. Good. Yes, review the beginning, please. Sub-fellowships. Once you do a fellowship, you can basically tailor your practice, or you can do another fellowship too, but to get really specialized and become an expert in a sub-specialized way. Yes, you can do that. Like if somebody wants to be the Y90 guy. Don't ask me what Y90 is because we'll have a whole session on it. But if somebody wants to be the Y90 guy, they can subspecialize in a sense by, in-house training while they're, out first year attending. They can really tailor their practice to that. All right. Okay. It is time for me to go. And it is time for me to pick this up later. And I don't know what case of the day is going to be tomorrow. I don't know. I'll figure it out. All right, guys. Hey, great discussion. Appreciate you guys tuning in. I'm going to upload this for the next 24 hours. I'll put it on YouTube after this. And then this is the last question I'm going to answer because this is the best question. Best question. How do I see the future of IR? Interventional radiology is seriously, is expanding beyond belief. I'm not even joking when I say this. If we can inject cement into people's fractures, if we can minimally invasively embolize tumors, if we can percutaneously embolize tumors without even having them go to surgery, if we can do that kind of stuff, there are interventional radiologists out there who are cementing and placing rods. I know if there's any surgeons who are going to watch this, but they're percutaneously pinning fractures, in arms. If they're minimally invasively embolizing the left gastric artery to cause weight loss, they're minimally invasively cryoablating nerves back here for chronic back pain. I'm telling you, the sky is the limit with this profession. Go spread the word. I'm gonna have fun doing this for the rest of my life. Hope you guys too. That's my sales pitch for today. But it's just because I love it. All right, guys, I'm out of here, and go check out the beginning of this because we talked about HCC, which was the answer to case of the day. I will talk to you guys later. Adios. Bye-bye.